I'm not hearing the theme music.
Okay, it looks like it's filling up pretty fast. We have 359. Should I go ahead and start with the announcements?
I think we should probably wait until
We had
we
over
reach the
600 people
500.
register. Yeah, so let's wait. I have
Oh,
a feeling we'll hit 500 pretty fast here.
okay. I'll wait then.
Leslie, would you sing the Bumblebee song?
No, I'm trying to get it out of my head.
Hi, everyone. This is Rachel Kramer. I just wanted to give all the attendees some information about continuing education before we get started. To kind of account for attending throughout the presentations, we will pause and present a poll for everyone to respond to. If you don't see the poll pop up on your screen, then if you can comment in the Q&A, you can type in anything, something as simple as here or continue education. And we will also make that announcement throughout whenever we break for the poll. The polls will last about 2 minutes. And everyone should be logged in on your own computer if you registered and want continuing education. If you are just sitting with somebody else, we have no way to track your attendance. So please go get your own computer to log in. And CEU should be hopefully available to the TechSolve portal within 2 to 3 weeks. Our computer programmer is very busy right now getting CEUs for the webinars and also for the conference. So we'd like to thank you guys for your patience with that. And now I'll hand it over to Dorothy.
Welcome, everyone. We are delighted to have you here today. So I am here as a member of the Telehealth Task Force Committee. This committee was started and it was established by the TechSalva Public Policy Group in September of 2018. So that was almost 2 years ago, or almost 2 years ago. And the reason we started this task force was we began to realize that a number of practitioners were starting to provide ABA services via telehealth, yet our profession really had no clear guidelines for providing ABA services at that time. Right around that time, CalABA came out with a policy statement, but we felt that Texas needed its own to incorporate Texas rules and regulations, and we wanted a policy statement to be based on research into the literature on telehealth, in particular providing ABA services effectively via telehealth. So we spent over the last year investigating, and we just now have posted our report. And so some of the information that we're going to be presenting today comes directly from this report, but we're going to provide a lot more details. I believe now, after CalABA, we are the second state association to release a public policy statement about telehealth. So, you know, this is an interesting time for behavior analysts. I don't think that there's ever been a time where something impacted our field so quickly and so dramatically. Behavior analysts everywhere are now scrambling to support our families via telehealth and to support them remotely. And you know, a lot of us, it's hard not to focus on some of the undesirable negative aspects of this situation. But I always like to see the silver lining in things. And I think that this is giving us a great opportunity to provide the types of services that are really important, but we often don't get the chance to do because they may not be practical. So many of us are providing most of our services directly to our clients, to children, adolescents, young adults, and caregiver training may be just a secondary part of what we do, and often just do in clinic. We don't get to the home, we don't get to observe what's going on in the home, or focus very specifically on generalization to the home and natural settings. And that is something that is a real strength of telehealth. And so I think that there are going to be some good things that come out of this. But one important message that we want to leave you with today is do not do this alone. And the fact that you're here suggests that you are reaching out to get that training, learn more about how to do this. But this is just the beginning. We're going to just scratch the surface today. And we encourage you to get more training, supervision, and support from people who have some experience in this area. Well, I'm delighted to introduce our panelists today. The majority of these individuals have spent a number of years providing services via telehealth and conducting research on telehealth services. And so I just want to briefly introduce our panelists. Dr. Gordon Borland is the owner and operator of Trinity Behavioral Associates in Arlington, Texas. He provides ABA services in a variety of settings to people with a variety of needs and access across the age span. He is currently Vice President of the TxABA Public Policy Group and Chair of the Telehealth ABA Task Force. Leslie Neely is currently an Assistant Professor of Educational Psychology at University of Texas at San Antonio. She is the Program Chair for the Behavior Analysis Master's Program and serves as Director of the Child and Adolescent Policy and Research Institute and San Antonio Applied Behavior Analysis Research Consortium and Clinic. Jessica Graber is the Regional Clinical Psychologist and BCBAD at Action Behavior Centers in San Antonio. She has been working in the field of autism and applied behavior analysis since 2008, and her work is focused on improving services for children with challenging behaviors, ethics in ABA, telehealth, and mentorship of BCBAs. Lucia Salmi works as a research associate at the University of Houston Center for Autism and Developmental Disabilities. Her research interests and publications include topics of assessment and treatment of problem behavior and parent training via telehealth. She's the founder of the Telehealth ABA World Project, through which parents and educators who work with children with autism and other disabilities in 30 countries receive behavior analysis training services. Kathleen Karimi, I apologize if I've mispronounced that, is the co-founder and CEO of Business Operations at Behavior Change Institute, a company founded with the mission of leveraging advanced technology to mitigate treatment barriers in rural and underserved communities. And I'm Dorothea Lerman. I'm currently a professor of behavior analysis at University of Houston Clear Lake, where I chair a master's program in behavior analysis and serve as director of the UHCL Center for Autism and Developmental Disabilities. Here's what we have scheduled to talk about today. We're going to be covering a large variety of areas. I am now going to turn this over to Leslie Neely.
Hello, everybody. So I am going to start. Let me share my screen here. I'm going to start by just giving everybody a orientation to some of the language of telehealth and some of the definitions. So some of these are actually pulled from the CalABA public policy publication they put out. But some of the technology or some of the language some of the language that they used is defining the different sites that receive and originate telehealth. So the people where that are actually the content experts and that are delivering these services is the site where the expert is located, the BCBA, typically called the origination or the host site. The site that receives the services are the distance or receiving site. That's typically where the patient or client is located at the time of service. And then there's two types of telehealth. The first is synchronous, the real-time interaction between the host and the distance site. That typically takes the form of video conferencing. Then there's asynchronous. This is where you transfer health information from one site to another without the patient or client present at the time of the transmission. And that's typically called store and forward. So this may take the form of videoing a client and parent interaction and then sharing that video via a secure network so that the expert can review it at a time later than the actual session. So telehealth is the provision of health services via the remote communication technologies, such as internet connection obtained via a smartphone. And typically defined as the modality, it's not a treatment itself, but the use of communication technologies to facilitate treatment. It's hallmarked by the distance between the expert and the recipient. So typically the host and the receiving site are at geographically different locations. And the services, so used to deliver healthcare services, standard of care is supposed to be equivalent to the face-to-face treatment. So this was the CalABA policy paper. I think they did a really nice job of kind of demonstrating the difference between the synchronous intervention and the asynchronous intervention. And a little bit later on, we're going to go over some of the research and the efficacy of telehealth ABA. But just to give you a primer, some of the research, most of the research actually has been done using the synchronous intervention. So this is where the ABA supervisor is at a distance site, computer and audio and video or similar device at the distance site and origination site. So they're connected live, and ongoing intervention or meeting at the origination site by the technician, parent, or stakeholder. There's somebody who's actually present on the receiving site as well as the origination site. And then there's live feedback going on from the ABA supervisor. So this is different than the asynchronous intervention that has less research to support it. But in the asynchronous option, you have the technician or parent performs tasks assigned by the supervisor. They may record it. They may do an audio recording or a video recording. They send it along to the supervisor at the distant site. The supervisor then performs the analysis of the data, maybe collects data from the video and graphs it and analyzes where they may need to tweak the intervention. And then the feedback and the instruction by the supervisor could be in real time with the parent or the technician via the, after they review the audio or video. Or it could actually be, via email or something like that. Oh, I believe it's Gordon's turn. Gordon is going to review the relevant laws and regulations in Texas.
Okay, thank you. Next. I'm sure everyone appreciated a night shot of our lovely state capitol building. But I think, Leslie, you have the switch.
I do.
This presentation this coverage of the relevant laws and regulations in Texas will be relatively brief, but we must provide a disclaimer, specifically that we are not here dispensing legal opinion. We are providing information for educative purposes only. So we want to be real careful about that. All right, next. We want to talk next about some general information, and this is taken from the report of the Texava Public Policy Group Telehealth ABA Task Force that Dorothy had just had mentioned a little earlier. Again, these are general, these are summary statements. We'll go over the information in a little more detail momentarily, but one of the take-homes from that review that we did was that after looking through the laws and regulations for the state of Texas for various professions, there were very few explicit references to telehealth in either the statutes or the rules. So there's general principles, and we'll come to that in a moment. Psychology, like the Texas State Board of Examiners of Psychology, does have some information regarding telehealth psychology. But again, one of the outcomes from that review was that to note that professionals who are providing telehealth services still do so under the regulation of the relevant state licensing entity. They are still required to meet the same standards of service as are in effect for in-person services. We can't get sloppy. Also, these requirements include pardon me, the provider qualifications, licensure, confidentiality, and consent requirements. And further, at this point, the indication is from the existing Texas rules and laws is that insurance coverage requirements are the same for telehealth-based and in-person-based ABA services. We know, frankly, that at this point that is problematic. Next. I want to talk now just briefly about consent. This is a quotation from the actual Texas Texas statutes, saying that a person providing telehealth services who make sure that we must get informed consent. That probably stands to reason, pretty obvious for most behavior analysts, but again, that is required. We're not allowed to just suddenly start doing it. Next is talking about confidentiality. And this is a big issue. It says that basically anyone doing telehealth services, whatever sort it is in the state of Texas, that means it's not discretionary, shall ensure the confidentiality of the patient's medical information is maintained. This is a very big issue. I am aware, we are all aware that there was presidential action last week that waived some of the some of the HIPAA confidentiality or the HIPAA requirements. That, however, would be at best temporary, and just my personal opinion is that I think good practice says don't get sloppy. Maintain good confidentiality, and there are things that I think we'll discuss later about how one goes about that, including what platform you use, business associate agreements, and so on. But this is, even though the waiver exists now, it's temporary. I think good practice says go ahead and try to adhere to a more significant standard. Next is insurance. This law, this part of the Texas code says private payers must provide coverage for, states that they must provide coverage for telehealth services subject to contract terms and conditions. So making that to be so at this point is difficult in some cases. And then next I want to look at briefly licensing and regulation. This specifies that any services provided via telehealth does not change basically the licensing authority's power to regulate someone that otherwise would be regulated. So that means in Texas, performance of provision of ABA services is still regulated by the Texas Department of Licensing and Regulation. That hasn't changed. There's no special dispensation for that at this time. Next, the question probably arises, okay, so specifically, what about telehealth ABA? Well, the short answer is it is not specifically addressed, at least at present. I do anticipate that probably will change in the foreseeable future. The licensure group functions will probably be looking at that. In fact, I know that's under study. But while there's nothing specific addressing telehealth ABA, basically still all the things that I mentioned just a moment ago, all those general statutes and rules still apply. Plus, in addition to those addressing telehealth, all the other statutes and regulations specifically governing and regulating the practice of behavior analysis still apply. So that's very important to know. So with that brief analysis, now for something completely different from Leslie Nielsen. Or Leslie Neely, not Leslie Nielsen. If Leslie Nielsen were here, that'd be pretty amusing.
I know. I like the Leslie Nielsen better. That's actually how I tell people when they ask how I spell my name. I say, well, it's like Leslie Nielsen. You know him, right? Okay, so I'm actually going to talk a little bit about the efficacy of telehealth ABA, what the research supports, and then the...
Sorry, can I interrupt while you guys are transitioning?
Sure, go ahead.
Hi, everyone. We're going to do the first poll for continuing education. I just launched it. It'll be open for 2 minutes. If the poll did not pop up, please just comment in the question and answer box with here or any comment. Thank you.
Okay. So I'll talk a little bit about not only what is supported by the literature, but also kind of highlight what is specifically absent for consideration. So I actually borrowed this slide from one of Dorothy's presentations, but she had this really nice graphic that shows telehealth interest within the literature and the number of published articles since 2000. And you can see a really nice slope indicating that within our literature base, telehealth, telemedicine, just these concepts have become very popular and getting additional focus within the last couple of years. I also am part of the Telehealth ABA Facebook page, something, I don't know if that's the exact word for it, but the exact title. But I pulled some of these for my talk that I'm doing at Texaba because I thought this was really interesting. A lot of BCBAs, I've seen a real increase in that group and some of the questions that they're asking. They're looking for telehealth positions. They're looking for flexibility. And then what I liked about this one at the bottom, she's interested in getting into telehealth as a BCBA, but she's also looking for a reliable company to help assist her with learning the ins and outs of telehealth. So I pulled this slide and these pictures probably about a month ago. Then I went back and I looked at, oh, it's telehealth and behavior analysis. There's the name of it. what has been posted recently in the last, couple of weeks with this new COVID-19 increased focus. And so now you're starting to see questions from people about, how to get insurance to approve it. They're sending articles to request specifically on the efficacy of technician-delivered therapeutic services. You can see the response is that yes, in Michigan, they allow parent training and group parent training, not specific supervision or direct telehealth. This next one, she was looking for resources for how to train RBTs in completing treatment through telehealth. So you're starting to see a shift in just kind of the social media interest of telehealth. And then if you look at the CalABA policy paper, they kind of went through this list of potential applications of telehealth. So you see previously people were asking, I'm a BCBA, I want to get trained, and now they're asking, how do I train my RBTs and how do I conduct direct treatment? And so CalABA does kind of list these options of conducting behavior analytic assessments, treatment planning, direct treatment, supervision, equitable access to services, caregiver trainings, consultation to ensure continuity, and discharge planning as options and potential applications of telehealth to ABA. But what I want to talk about is actually kind of what the research supports, because all of these are definite needs, but the research is not there to support all of them. So you can't talk about telehealth without talking about Dave Wacker, the pioneer of telehealth ABA. Also a slide from Dorothy, there's Dave's picture there. And he really pioneered, the application of telehealth to behavior analysis, and in particular to the functional analysis of problem behavior and functional communication training. And I believe he is recently retired as well. I also wanted to point out 3 resources, some articles that I've seen circulating also in that Telehealth ABA Facebook page. And there's 2 kind of focused on training technicians, training caregivers in ABA. And then this last one at the bottom by Ferguson et al., Telehealth as a Model for Providing Behavior Analytic Interventions to Individuals with Autism. And this one is a little bit different in that it focuses on telehealth as a modality, in particular for the behavior analytic interventions, as opposed to the other 2, which have focused predominantly on training, using telehealth to train caregivers or to train an RBT, say, that's in the home or at a place that's separate from the expert. The Ferguson et al. Article, I pulled out just a couple of the stats and that I thought were most relevant. And so the use of telehealth in ABA, you can see the little pie chart there at the bottom. 43% of the articles that were included in the publication focused on functional analysis. The next biggest chunk was incidental teaching or naturalistic communication interventions, followed by preference assessment, behavior support, and then a smaller chunk looking just at providing knowledge and overview of ABA. So there were 28 total studies that were reviewed, but only 96 of the studies were rated as weak due to low levels of the therapist's fidelity. There was also low quality ratings, causing Ferguson et al. To conclude that ABA via telehealth is not an evidence-based practice. And they also kind of mentioned some overlooked strategies such as DTT, functional and daily living skills. And these are the other 2 that were focused on training that I would recommend that you review as well. I will point out, I think Tomlinson had the same conclusion that there was not any quality studies. And then Neely, that's my article as well, we did not do a quality evaluation, just a systematic review. So after kind of taking a look at all of this, looking at these publications that came out, I really had the thought, it was last January, I thought, but what is the quality of behavior analytic telehealth literature when we're only focused on the subject outcomes? So these are the children that we serve or the adult clients that we serve. The other literature reviews, they weren't exactly focused on that. They were kind of doing more of a how has telehealth been utilized, and essentially concluded that it's been predominantly used to train others when the expert and the implementer are not at the same site. And then what are the effects of behavior analytic assessments and intervention delivered via telehealth on the client behavior? So I'm going to present, this is unpublished data, so kind of hot off the presses, or not even on the press for you guys. So you guys can have a really good understanding of what does our literature base support. So we conducted a systematic literature review. We then evaluated the resulting studies using What Works Clearinghouse design standards, conducted an effect size calculation, and then a moderator analysis for some variables we thought might be pretty interesting to see a comparison of. So the lit review results, there were 40 articles that met inclusion, so they reported outcomes for the children or the individuals receiving ABA therapy. They included 404 participants ranging from 1 year to 57 years old, with the majority of the studies really focused on that 1 to 16 year age range. Majority of the individuals were diagnosed with autism, PDD-NOS, or developmental disability. And you can see the breakdown of the dependent variables still pretty heavily focused on problem behavior, communication, some on task completion, and then social skills. We found we took all of the interventions that were utilized and kind of broke them into 4 major categories that we saw emerge. The first being assessment only. So these are articles that only conducted a preference assessment or only conducted an FA via telehealth. The second were behavior interventions and strategies. They did not conduct an assessment. They only were demonstrating behavior interventions. Manualized interventions. So this is the Early Start Denver model, the IPEX, Project Impact, Ruby parent training, reciprocal imitation, and Sunny Starts dance. These were pretty heavy in the early childhood inclusion of the early childhood age range. And then naturalistic developmental behavior interventions, that's your incidental teaching and naturalistic language intervention. So you can see that 30 of those articles, or 30% of those articles, were manualized, but it's pretty well broken down in 30, 20, 25, spread out between assessment intervention, manualized behavior intervention. Then we did the quality review and said we did find 40 articles, 6 of them were group experimental design, meaning a larger N, and they included a experimental group and a test group, or they were quasi-experimental. We evaluated the single case separate from them and found that a majority of the single case studies did not meet the single case research standards, but that about 40% of them did either meet the standards or meet with reservations. And predominantly when they met with reservations, it was because of the inter-observer agreement being reported as 30% of the study sessions, but not 30% within each section, each phase of the study. Of the group, there were 6 that were included, and only 3 met the quality standards. So the 3, and I kind of just threw them up there in case you guys were interested in looking at these articles. The Bishmar et al. Article is about Early Start Denver model. That's a manualized intervention. So you would have to get, you wouldn't be able to implement that on your own. The other one was a face-to-face versus online behavioral parent training for ADHD. And then the bottom one was a RCT comparing self-directed versus therapist-assisted telehealth for parent-mediated intervention. And what that meant is they had 2 groups. One was parents who accessed the manual and kind of taught themselves how to do the intervention, versus one that had a therapist there to support them, and then they still both groups still connected with the expert via telehealth. The other 3 studies that were included in the literature review portion did not meet the quality standards for group, predominantly because they did not have an experimental, they did not have randomization between the test and the control group. So this is the part I think is actually kind of interesting. So we did our effect size analysis, and then we were really interested in, but how, if we kind of categorize these effect sizes, how do these different categories compare? And so we asked kind of 6 different questions. The first was, what was the difference between on-site plus telehealth, so a integrated model, versus telehealth only? And so we aggregated all of the effect sizes for the 2 categories, and you can see they're actually pretty equivalent. They 0.55 versus 0.51, pretty equivalent in terms of the model, indicating no real big difference between on-site, an integrated model versus telehealth only. That dotted line you see, though, indicates that that's the cutoff for a small effect size. So we use the tau U effect size, the non-overlap measure for those of you interested. And there is guidance from Parker et al., who kind of pioneered that effect size, on what the cutoffs might be for small, medium, and large effect. So below that cutoff line, that dotted line, every one of those bar graphs that hits below that line is a small effect. If it hits above the line, it's a medium effect. And if it hits above that second line, it's large, although there was no large effects that we found. So if you look at this second category that looks at implementer, this is whether or not a caregiver implemented the intervention and was coached by an expert at a distance, or whether the therapist, there was a therapist there that implemented the intervention and they were coached by an expert via distance. And what you can see here is there actually is a pretty big difference, 0.46 small effects for caregiver implemented, getting close to that cutoff, but not quite. And then the 0.66, so a little bit more effective for if a therapist implemented the intervention. And then very interesting, and I'll kind of talk a little bit in a couple of slides about this, but dosage, we indicated, or we categorized dosage as low versus high dosage. And the low dosage was about 1 to 2 hours a week for up to, I think it was 10 weeks. And then the high dosage was anything above that. And so you can see that it actually, we saw that there was better effects for the low dosage versus the high dosage. But as I'll talk a little bit later, we didn't get into the why of that, the mediators of that. There's a lot of different factors that could explain that potentially. So that was kind of the delivery of modality. The second thing we were interested in is the different skills that were targeted. And so on this graph, what you see is the different bar graphs represent the effect size. The first one on the left is the skill. And so this is whether or not the study was targeting problem behavior versus communication. And so you see actually just barely meets the cutoff for a large effect, or a medium effect for all the studies when they were combined. If they targeted problem behavior, they had a slightly larger effect on the child's skill. If they targeted communication, they had a smaller effect. If you're looking at communication modality, so we saw AAC as a outcome for the children versus spoken language, and actually those effects are exactly equivalent. So no matter if they were using some sort of AAC device, picture exchange, or speech generating device as a communication modality versus spoken word, the outcomes were equivalent. And then this last one we were interested in is we saw a kind of recently in recent literature, a change from very simple communication, so one word mands, to more complex communication, getting into tacting and larger 2 to 3 word mands or larger sentences, stuff like that. And so we were interested in, is there a difference between the outcomes for children if we are only focusing on the simple communication, that was one word mands versus complex, And you can see they're both very small effect sizes, but there is a substantial difference between complexity of intervention or complexity of the communication versus simpler communication outcomes. So that's all the data, but what does it mean, right? Because that's kind of the important part. And so the some of the big takeaways from this is that there's best support for training others, where the implementer is at the receiving site with the client or patient. Of course, that is not ideal conclusions for today because we have to be really thoughtful about protecting the health of the clients as well as the health of our implementers, our RBTs, our technicians. The result from the moderator analysis suggests that treatment effects may be the most robust when the intervention is implemented by a therapist, targets problem behavior, and combines telehealth and on-site intervention procedures. I will note, though, we did not conduct any sort of significance testing, and so we don't know if the differences in those effect sizes are significant. So that is definitely kind of an area that we should investigate in the future. There was some interesting results of this low dosage versus high dosage. There's a lot of things that could be mediated or that could mediate that. It could be the complexity of the skill targeted in the high dosage versus low dosage or the participant characteristics. It could also be mediated by baseline levels of problem behavior. That's one of the issues with using an effect size, a non-overlap, is that if you have very low baseline levels and then very high intervention levels, you start to have inflated effect sizes. And the one article that I kind of referenced, DuPaul and colleagues compared the face-to-face versus telehealth. One interesting thing I found from them is that the effects were similar, so equally equivalent face-to-face versus telehealth, but the face-to-face was rated more acceptable as compared to telehealth by the families who participated. So I think that's a kind of a limitation and something we definitely need to consider as moving forward, is that face-to-face modality is absolutely different than telehealth. And so setting up, I think, just maybe talking about the differences in the two modalities and ways that you can communicate those differences to the clients. Additional limitation, it's only been a year since we did our search, but there have been new publications. So I know one of Lukia's publications here, I think, kind of gets at that point number 2. Just published out there, I think September 2019, that says, or 29, yeah, that's right. In effectiveness and acceptability of parent training via telehealth, and they did find that the parents receiving the telehealth rated it as highly acceptable. So that's kind of where the literature is, but almost as important is what is absent from that literature base. And so they're very absent focus on other skills. It seemed to be primarily on that problem behavior and social communication. Also absent is direct instruction, where the host site directly implements with the intervention with the recipient. So all of the interventions, all of the studies actually had a implementer, either a caregiver or a therapist at the receiving site. Also absent is literature on how to train others to conduct telehealth trainings versus training others via telehealth. So that's something that we have started to work on because obviously now it's a little bit more urgent, but that was one of the things that had crossed our minds in the past. And I think Dorothy is going to present some of our preliminary data towards the end of this presentation. And it's pretty unknown what the impact of telehealth ABA is over time. So do these children retain their skills? Are they improving? As compared to face-to-face, is it equally effective? I kind of want to go back, though, to those postings we saw, right? Because they're asking the questions that are absent. So how do we train technicians? How do we conduct direct services? And so really this whole COVID-19 kind of brought up the big research to practice gap, because the research questions that we had yesterday are the practice issues of today. So it definitely increased the focus on telehealth, and I think there's quite a lot of work left to be done and probably needs to be done quicker and sooner rather than later. I think that's the end of my slide. Yes, okay. Let me turn this off. And Jessica Graber is going to be presenting next on the different modalities. Jess, if you want to take it over, I think you have to share your screen.
Ooh. Okay. So actually, I'm using a different computer than usual. So Leslie, will you just keep sharing yours? Because it seems like I have to set up my preferences to do that.
No worries, I'll do it. Give me 1 second to get back into it. Are you able to see it?
Yes.
Okay.
All right. So the question is, some people have been asking, or the natural question given the circumstances that we found ourselves in is, can't we just switch to telehealth? So Leslie has been discussing some of the ethical, or not necessarily by talking about ethics, but in reference to our ethical code, we need to rely on the scientific knowledge of our discipline in making treatment decisions. So Leslie has been talking about the limitations really in our scientific knowledge of how to apply telehealth best for our families and for our clients. So I'm going to be talking a little bit about how you move forward given that information, but also considering the individual and our ethical obligations to involve the client in the planning process and the individualized behavior change process that we hold so dear in ABA. So you can go ahead and advance. So this is an eco-behavioral model diagram that I borrowed from Google, and it shows really the dynamics, the dynamic variables that are influencing the child and the family at the center of the diagram. So Leslie, if you'll scroll over the little family holding hands there, or that mother and child. Without clicking, but so right there in the center, that's where that dynamic is that we care so much about. That's our target for treatment, and really the child in particular. But if you look a couple layers outward, the environmental components and resources available, that's really where we typically live, is so a couple degrees, pretty significant degrees of separation from that dynamic. If, say, we're treating in clinic settings, or even if it's a therapist going to the home, but there is face-to-face intervention happening primarily between a certified therapist and the child. So where we're finding many of ourselves in needing to jump through those levels and then reach the home via a new modality like telehealth, there's a lot to consider there. Clearly there's the limitations of
So you should let an adult cut your hair, okay? Mom or dad.
Berenice is talking about cutting hair, I think, which is very important. And that's a great example of kind of what different dynamics might be happening in any given moment for a family.
I'm sorry, guys. I don't know how this got unmuted, and I had one of my families that needed to.
It was perfect.
Sorry about that.
It was awesome. So that's a great example. You can't know what's going on in the home context. You're jumping through all those different layers there you're crossing the barriers of culture, all the knowledge of the individual family members, where that child is in treatment. But then also you have this, the time, age, cumulative experiences in the background. And right now that's a global pandemic that's influencing everything. So these are all dynamic variables, and there's a lot to take into account when you're trying to translate services into a completely different modality in a different setting. So go ahead and advance. Here are some of the basic differences between in vivo or face-to-face service and a telehealth service. So typically in vivo, we have a trained and certified therapist administering the treatment, maybe with BCBA supervision, or the BCBA is doing it directly. Rather in telehealth, when you are, say it's telehealth and direct coaching of a caregiver, it's the caregiver implementing completely different learning history in terms of their background in ABA, and a very different emotional element to the treatment as well, you know, a very different dynamic. With in vivo, we have the two people either in home or in a clinic-based setting. And in telehealth, we have the client with their caregiver in the home and the therapist or the BCBA interfacing via computer. This next bullet has been something that I think people didn't really think about as much until we found ourselves in this situation where we're needing to consider what this actually looks like. So typically in vivo, we are providing a much higher dosage. So say for kids who are already getting services or they're already hooked up with ABA, they're typically getting a much higher dosage of those services than is appropriate to offer via telehealth for a number of reasons. In particular, families have other children in the home. Families might be trying to work from home right now, and the therapist might have an additional caseload, but also the context is just set up completely differently, such that the infrastructure isn't in place to support a very high dosage. So that's one aspect of why that dosage tends to differ so much. Also in vivo, the skills that you're working on can be very comprehensive, and that's a pretty typical model for lots of kids that are getting regular ABA services. Relative to telehealth, what has been done so far and what tends to make sense is a more focused program to go along with that lower dosage, but also there's a real emphasis on key skills and generalization. And so I am tying this discussion primarily to our current circumstances. That's what's relevant for all of us right now. And what we need to be asking ourselves is, what are these key skills that this child needs? And what are the things that we really need to generalize to the home in order to maintain the progress that we've made and help with generalization as much as possible, relative to comprehensive new skills being developed. Of course, in clinic, it's a very controlled context. Even in home, typically if you're getting regular services, there's an area set aside that's reserved and set up just to provide ABA. So there are programmed discriminative stimuli. There's very clear signals to the child about what the expectations are, and signals to the rest of the family about what, say if it's in home, about whether or not families should be getting involved at any given time. And if it's in a clinic, it's even more controlled, right? And so we have literally like programmed distractors or no distractors. But with telehealth, you have very little control over those momentary changes in the context that the child is in. So that your session structure and what you're working on really needs to be tied to what's meaningful in that context. Go ahead. So I think in examples, things make a lot more sense to me that way when I'm just trying to think of cases. So this, as a hypothetical case, that's sort of a conglomeration of different experiences. And so we'll talk through it to imagine what this might look like. So before COVID, this child, let's say, was, let's call him Micah, was receiving intensive early intervention ABA therapy in a clinic context, a 3-year-old with a moderate level of autism, and has been in treatment for a couple months. They've made a lot of progress. They have independently mastered 5 MANs that they're using, not consistently, but they have 5 MANs that they can use independently at times. But there's a history of tantrums that involves flopping, that can involve hitting the head if the child flops to the ground and can hit their head in the process, screaming, crying, and the function has been identified as escape. But again, a lot of progress has been made in clinic over the last few months. So typically this child has 1 BCBA case manager and 4 RBTs that are rotating in providing treatment to this child. So very systematic generalization that's happening there, but all within the clinic context. The parent training up until COVID was happening, say, every other week for about an hour. And more often than not, that looked like the parent coming into center, sitting in a conference room and talking through the child's treatment program. They'd gone and observed, maybe begun to do a little bit of hands-on, but there's really been a lot of therapist support throughout that process. But the child's making great progress. Then COVID hits. So go ahead and click. And now we have a public health emergency. Public health disaster, some people are, can say. So what we have to consider is, if you think back to that diagram we were looking at, the whole context of what's happening legally at the government level, and how all of these meta level variables are influencing that individual child and his needs. The family also has their needs. So for this family, both parents work full-time. They have, there's a younger sibling in the house as well. They are upper middle class, but they are very hardworking and have a lot going on in their lives. They also have the grandparents that live just down the street, actually, and grandparents are very involved with the child, but they're much older and they have underlying health conditions. There are organizational needs for the therapy center that's been providing treatment. So they have tons of employees that they want to keep employed. So they have revenue requirements. They also have safety requirements, all of these different kinds of things. They have their structure and their style of how they typically provide services. There's the BCBA right there. That's when we're talking about boundaries of competence. That's another one of our ethical standards that we need to follow. So this BCBA has had very little telehealth background and experience. They do video conferencing a lot with work or with friends, and maybe have observed a couple telehealth sessions, but have had very little direct practice. The RBT and the behavior therapists, some of those staffing abilities are changing right now as some staff are leaving, as staff are concerned about their own health and safety. So there is all of this flux happening here in the context. Go ahead and advance. So the choice is for this particular case example to immediately pause in-person services. So this choice could be made because the organization decides that that the public health concerns demand that, or it could be that the family has decided our grandparents live down the street and this is absolutely not worth the risk of our safety and our family. So we have to stop all in vivo exposure to any potential threats of COVID. So we're going to stop in-person services. Go ahead and advance. And your choices are, right, some no service at all or some level of telehealth support. The choice there is pretty obvious. You're going to try to do something. I say obvious in this case. So this is an English-speaking family. They do have resources. I said they were upper middle class. The child has made a lot of progress in ABA, and you're working largely on manding and decreasing problem behavior. Things that we discussed earlier are relatively established in the literature for telehealth. Some level of telehealth service has got to be better than doing nothing at all in this case, especially because we talked about the child's challenging behavior. It can involve headbanging through part of the child's tantrums, which can be life-threatening. Go ahead and advance. So now we have to ask these questions. And I actually didn't, probably the first bullet should be, what are the resources that the BCBA needs in order to help facilitate this, or that the organization needs to facilitate this? Because like I said, the BCBA had very little experience so far with telehealth. So one thing that you can do is you can seek out professional development by participating in events like this, reaching out to former mentors and teachers that you've had. Sometimes you reach out to authors in the field. So you reach out, you get that kind of needed information. But then on the individual level, you have to be thinking about dosage. Okay, so what is a feasible amount of telehealth that I can provide, assuming that I get the training and support to do it? What goals do I work on? What should the environment look like? How do I prep the parent for all of this? What kinds of materials do I need for that first session and going forward? And what materials do the family need to set it up? What is the structure of the session going to look like? So let's go ahead and advance. Okay, so in this case, the BCBA did seek out support from a relative expert in the field, let's say, and got some discussion and in vivo support during her first couple sessions. And they reached out to the insurance company and said, hey, what can we do? There's no way that we can provide in-person support. What can we do in terms of parent training via telehealth? What will what will be reimbursed. So they might come to an agreement at about an hour to an hour and a half every day, 5 days a week for the next several months is what we can approve. Let's say the insurance says that. And then you have to figure out what you're focusing on, right? What are the goals given that dosage, okay? So in this case, I would recommend focusing on key skills that are going to be critical for this family to survive, to survive and be as happy as possible and have as positive interactions with each other as they can. The number one thing there is pairing, right? We can't really be working on or be very successful necessarily with FCT, with some of these deeper, more complex things until we can really teach the parents what free play looks like. So you might work on that kind of thing first. Differential reinforcement, how to reinforce appropriate behavior at large. And then moving into the specific type of DRA treatment, maybe FCT. With the environment, you're coaching the parents in what are we going to do with baby sister during these sessions? What about the animals in the house that keep running in? I see Lucia nodding. She's seen so many like cats and so many awkward things crawling over the keyboard, I'm sure, in these telehealth sessions. So might set up 2 different areas, one area for play, one area for work, depending on what kind of program you're working on. And then at the host site where the BCBA is, she needs a task analysis, a fidelity rubric for how she's going to be determining whether the parent is making progress in the target skills, maybe taking data on the child behavior as well. How is the child making progress? You got to have all of that set up, of course, in addition to your technology, your internet connection, those tricky things. And in the client home, they're looking at what do they need to have. So sometimes you see parents, they have no idea what they're supposed to have first. They're trying to make it look like clinic, and you have to really coach them through each thing one at a time. Structure, are we going to observe and then provide feedback, or are we going to do it together? Are we going to do it synchronistically? So we're watching and we're commenting as it's happening. You might do a little bit of both. You might have some baseline observations, intermittently just see how the treatment is going without you interfering, but then you're also commenting at other points in time to get them through difficult situations. Go ahead. But this just is one case, right? One very specific child. And they only had one other child. They had a lot of resources. We had the same language fluency. Other variables to consider that might make this look very different are caregiver variables, like the parent's availability. So maybe you do have a family where there's just one child in the home and the parent isn't working, and they also say have a lot of experience, relatively speaking, in ABA. Maybe they're beginning an ABA program because they would like to become a BCBA themselves. That might look very different. That might gradually and more quickly look more like direct intervention where you have a therapist there implementing with the child. It really depends, but that would be very rare. Most of the time, these are parents that are balancing a lot of different things to get through an hour with their kiddo. You might also have to consider maybe telehealth isn't such an obvious choice if the family doesn't speak the same language as the therapist and there's nobody there to help with interpreting. Because in that case, with telehealth, you rely very much on your verbal descriptions. You can't just jump in and model. All right. And then you also have to consider, go ahead and advance. Thank you. The child variables. So the age of the child, this was a 3-year-old that we were talking about, but it might be an older child, maybe one who's in school and is getting a lot of homework. And so the parents, whether or not you're there, are trying to struggle through hours of homework every day. In which case you might be able to do a much higher dosage that's still very relevant to the family's needs. Also, level of autism, intellectual disability, relative skills. So we're doing more and more socialization via electronic means. So it might be very appropriate for kiddos who are working on social skills to actually practice that with maybe their RBT or other peers via webcam. So there are other ways that you could get at some of the skills, just depending on these very specific variables. Go ahead. So in summary, switching between telehealth switching between in vivo to telehealth, no, it's not apples to apples. We can't just switch. We have to really look at a different kind of service with different strengths and weaknesses. And we're considering those client, caregiver, organizational, BCBA therapist variables and determining what that dosage and what that service looks like. It has to be tailored to the home context in terms of all of the goals and the practices. Go ahead and click. So that dosage might be much less, maybe, but a little bit may go a really long way and a uniquely long way when it comes to doing telehealth in the home. And that's the end of my section.
Okay, everyone. We're going to do the second poll now for continuing education attendance. I am launching the poll right now. It will be open for 2 minutes. If you do not see the poll, then please comment in the question and answer box. You can say here or just say you don't see the poll. Thank you.
And Rachel, would you like to wait until the polls close to go on?
It looks like we've already had the 88% respond. So I think we're okay to go on if you're comfortable.
Perfect.
Thank you.
We can advance just one slide, please, Leslie. Thank you. That was great, Jessica. Thank you so much. And I think that really sets this next section up pretty nicely. So I'm Kathleen Karamy, and I'll be providing an overview of the ethical considerations and risk mitigation today. We'll start by talking about the BACB's Professional and Ethical Compliance Code, which states that clinicians must act in the best interest of their clients when making decisions. In the setting of COVID-19, our clients and families have been facing great disruption. And as we know, disruption in ABA therapy can have significant and negative consequences on our families and our clients, such as regression in adaptive skills and an increase in maladaptive behaviors. In addition to compounding family stress, clients affected by an abrupt treatment disruption may be at increased risk of emergency room visits and hospitalizations. So we as ABA providers really have a responsibility to help our clients in maintaining access to medically necessary, safe, and effective care to the extent possible. And as Jessica was setting up, what can be delivered safely and effectively via telehealth is going to be very different for every client. So within my organization, which I'll add, already integrates telehealth technology into almost every single client's care, we currently have just under half of our total cases out of service right now. Because either the staff is being quarantined or the client or family is being quarantined for various reasons. So we have started to establish contingency plans to help our clients and families maintain access to treatment in the event a family is quarantined and unable to receive the extent of on-site care that they have been receiving. So we'll talk a little bit about what this process looks like, and I'm sure within your organization and practice, there are many other things that could be added in here. First and foremost, want to make sure that the funder covers telehealth services and that we understand the extent of coverage. It's really important to pay attention. These guidelines have been changing daily, and there are enhancements that are being added by single funding sources throughout the day. So it's important to pay attention and make sure that the funder covers telehealth, because billing fraud is not just an ethical violation, it's also a criminal violation with very serious consequences. So the other piece of this, which we'll get into a little bit further, is just because you've been approved for telehealth, really needing to make sure that we understand how to bill for telehealth and making sure that the claims that we submit to our funders represent the fact that a telehealth service has taken place. The next consideration is, does the family have access to necessary technology and an internet connection? So within my organization, we provide all of our technicians with tablet technology, some with mobile hotspots for internet connection. There are a lot of families that we serve in our rural communities that don't have access to the internet and they don't have home technology. So within our contingency plans, we're trying to make sure if there is a technician that cannot go out to the home, what's the plan for the family being able to log in? So how can we ensure that protocols are set up to provide the necessary technology and internet to our clients and families? And how are we going to monitor that and then get that back when services move into another model or are terminated? The next consideration, and I think it's one of the biggest, is just understanding the client's behavior profile. So is the client exhibiting severe challenging behavior, self-injurious behavior, or suicidality? If so, telehealth might not be a safe and effective model, so that really needs to be evaluated very carefully. How competent are the providers? So is this someone who has provided some extent of telemedicine in the past, or is this the first time that someone will be practicing telehealth? Providers practicing telehealth for the first time require very basic supports and training, such as just understanding how to set up a telehealth home office. I think we can probably all attest to working at home for the first time and just being very conscious about what our background looks like, what the lighting looks like, what we look like when we come on screen, that we're smiling. It's not intuitive to everybody. And so I think that really robust training, content, and resources are required to set up safe and effective services. The other thing to consider is the environment. So if you're moving from clinic to home, for example, does the home setting offer a therapeutic environment? Jessica was mentioning that in some locations, there may be multiple siblings, constant distraction, maybe the caregiver is not available to engage in session. So all of these things should be considered. If you're providing services in a location outside of home, or you've been providing services in home and the technician is generally bringing in therapeutic materials, how can we evaluate what therapeutic materials are essential and ensure that they're at the home for the child during therapy sessions? The next piece is, do we have a crisis plan in place? So do we have local emergency numbers in the unlikely chance that one of the caregivers has a medical emergency during session and we're the provider on the other end, the only person at the home other than the caregiver is a child? What is our plan to respond to that? If you have out-of-state clinicians providing telehealth to patients in new states, understanding what those state-specific mandated reporting requirements look like, and how providers can file the necessary reports. And then taking all of these things into consideration, I think we need to ask ourselves, to what extent can telehealth be safely and effectively integrated? And what are the benefits and risks associated with discontinuing care versus integrating telehealth? And I think this can, again, look different for every client. It could be discontinuing one-to-one for a period of time and moving to a parent training only model. Or some funders right now are opening up codes like 97153 for telehealth. And so I think it's going to be evaluating to what extent can we provide safe and effective care, and approaching that question through an individualized patient-centered lens. Okay, you can advance one more time, please, Leslie. Thank you. Just wanted to mention there are a lot of great resources out there, and related to what we're talking about, the Council for Autism Service Providers has put out some great organizational guidelines and standards. There's a whole section on telehealth, and at the end of this week, the CASP organizational standards has also had a telehealth task force working to develop service-specific guidelines. So actually going through each of the Category 1 ABA codes and providing a list of considerations that providers should work through before they decide to implement any of these single services through telehealth. So that is all I have, and I will hand it over to Lucia, who's going to present on technical considerations. Thank you.
Lucia, you're still muted, I think.
All right. Hello. My name is Lucia Tsame, and I am delighted to be presenting today about technical problems in telehealth. In 2015, I was working at the Autism Center at the Center for Autism and Developmental Disabilities at the University of Houston, Clear Lake. See the picture on the left with a boy at the center. Dr. Dorothea Lerman, our program director, asked me if I would like to work with her on a telehealth grant. Although I did not have much experience, I didn't know much about telehealth, I accepted because I love the environment, the university, and the research project we were conducting. I am one of the least tech-savvy people you will meet. An embarrassing fact about me is that until a couple of years ago, I didn't know anything about Google. I was lucky to be trained by the best. Dr. Lerman sent me to Dr. Wagger's lab for telehealth training. For 3 days, we reviewed protocols. I watched videotape sessions with our telehealth clients. We role played. I watched live sessions. Here on the bottom right is Dr. Matt O'Brien. We talked about problems they had and difficulties with their clients. I learned a lot. I left Iowa with instructions and manuals and protocols for my clients. So after 3 days of intensive training, I really felt confident and ready to start telehealth in Houston. This was not the case. This was not true. I was terrified for all the technology I had to use. Telehealth was a scary new modality for delivering services. I felt like I had no choice, but so I jumped into it, although I was scared because a lot of changes were happening at the same time. So from seeing a few kids in the clinic for many hours, my days changed to seeing many parents for a few hours each. I had 3 to 5 one-hour appointments every day, each appointment with a different family. 5 appointments was kind of my limit. I tried 6 and it was too much for me. So the 5 appointment days went really fast. I was conducting research, so it might be a little bit different for clinical practice. I also had other duties. I had to recruit participants. We had to schedule diagnostic evaluations and collaborate with the psychology department. We had to score and code the videos of our sessions, so this took a long time. And also I had to train and supervise students. So the times that you may have available can be different. The last 5 years until April, I only delivered services through telehealth. I worked with over 150 families. I conducted over 130 assessments for problem behavior, which was the majority of my work. I wrote behavior reduction plans. I coached parents to conduct toilet training. We conducted a study last year. We are in the process of writing the manuscript and hopefully soon submit for publication. I coached parents to teach activity schedules. I highly recommend you working with activity schedules and help them how to structure their day, help the caregivers. I coached parents to increase compliance with daily routines for their children. One of the UHCL students, Taylor Custer, conducted bedtime, help with bedtime routine study. And I worked with toothbrushing, helping with toothbrushing, and also taking baths and showers. So there is a lot that you can do at the home environment. I also conducted ABLES with a few families through telehealth and preference assessments. I taught parents how to increase communication skills for their children, MAN training, PECs. And last, I delivered 62 presentations via telehealth, including a presentation in ABBA 2019 in Sweden a few months ago. I look forward to a successful online TechSaba this year. Because of my experiences, I may be able to help with a few tips about technology and telehealth. Since I have been working with Dr. Lerman, I had opportunities to conduct and participate in research projects at the University of Houston Clear Lake. Lerman et al. 2020 is currently in press and has useful advice about challenges and solutions related to telehealth based on experiences of 18 practitioners across 4 research institutions for a period of 4 years. Based on my experiences and the experiences of my colleagues, I will share our methods and techniques of how to prevent and solve technical problems. So, in order to be HIPAA compliant with the software you use, you must have a business associate agreement. It should be BAA. And the software that I am familiar, that I have used is Video, VC, and Zoom. This is the most common ones that I have used. And let me see my notes. So we follow Dr. Wacker's model. They have extremely large screens. If the therapist that is providing the services have a choice of using a large screen or her phone, I would recommend using the bigger screen. Our families here, there is an analysis that we did with 60 participants who completed, I believe, functional analysis and functional communication training. We asked them to use devices they already own. So for these 60 families, here is the breakdown. 37 chose to use their phone, 11, they used their laptop, and 8 used a tablet, iPad, and 4 of them used a computer. These data are over a year old, so since then, I don't think I had any family use a desktop computer. Most of them, use the first 3 devices. All right, consent. We must obtain consent for services via telehealth. We should explain how services may have limitations through this modality. Jess did a very good job explaining, limitations of telehealth. In vivo, we can arrange the environment, but when we provide services via telehealth, we are depending on the caregiver to follow instructions. Also, it's possible for a third party to enter the call. It is important to communicate this with the caregiver, and we have an example of consent in the resources. So, technical problems. We recommend developing a technology manual, a task analysis with detailed instructions for caregivers on how to use the specific software that you will choose to use. You can send the manual to the caregiver via email before the appointments. Although, about hardware, although we ask the parents to use devices they already own, you may need to let them know that they can use the smartphones, as many may think that they can only use computers or laptops or iPads. Ask them to consider before your session where in the room they will position the device and the possibility of using a tripod or stand. They may consider adopting MacGyver techniques and make their own stands or cases with duct tape or other material that they have at home. If they have to choose between using an older laptop and a newer phone, I would recommend using the newest smartphone. The newer the device, we seem to have less technical issues, and this is just my observation. If possible, ask the parents to use 2 devices, but remember to mute one of them. 2 devices can let you have much better view of the room they are located. And I would recommend also using a smaller room with a door. Also, I mean, depending on the program, smaller room with a door for functional analysis and functional communication training. Also consider hiding the devices, especially if your clients are higher on the spectrum, to avoid reactivity effects. Phones are much easier to hide. Also consider headsets, Bluetooth for the parents, especially if the clients, again, are advanced learners and the reactivity effects occur from listening the directions you give to the parents. About software, make sure you explain to the caregiver whose account they will use. When using Skype, many people did use Skype and many still do. Both parties must have an account, just like when you use the phone. When it's time to communicate, one person calls the other. However, depending on the software, this may not be the case. And in fact, creating an account can be a problem. When I used the video software, our university had an account. The University of Iowa and our university had an account. And I had to send an invitation to the caregiver to my account. If I didn't communicate this to the caregivers, the people who wanted to prepare for the appointment sometimes tried to make their own account, and this created problems. One of the caregivers even paid a fee to have an advanced account, and there was a good ending because the company was able to cancel the account, the submission, and refund. But having a different account often resulted in confusion and delays in therapy time. So familiarize yourself with the software. I would advise to find 2-3 friends who are not good with technology and send them an invitation to chat using the software you plan to use with your clients. Note the difficulties that your friends will have or your family of the software, and make sure that some of these difficulties occur with your parents as well. So figure out how you're going to describe to solve the problems. I use my aunt. I have a 72-year-old aunt who lives in Greece. So I conduct a test with my aunt every time we change the software or we update the software or I want to test something else. So she has been a great teacher for me. Essential is you need to make sure that your clients have fast internet. Sometimes having internet does not necessarily mean that it can support video conferencing. So you can test. Anybody that has registered to go to ABBA, they have sent a link that you can click on, and there is many available online that you can send to your clients to test their speed. And it is very useful to do this test at the very, very early stages when you are considering if telehealth is appropriate as a modality, so you can avoid, wasting your time and their time and looking at consent forms and other documents that you may need to communicate at the beginning of the services. So we have had clients that we could not support them through telehealth because the internet speed they had was low. We had to discontinue because of weather conditions that slow down the internet speed. So here are some data that indicate that you're not going to have many problems. So on the left side, there is a pie that shows our US participants. This is 29 participants and a total of 424 appointments. And on the right side, we have 26 participants, 320 appointments. So you can see on green the sessions that we had the whole session without a problem. So you see the percentage of appointment completed. So for most of your sessions, it was only 1.6% that we were not able to conduct the sessions. And what happened was the first time that we started, working with a family, the first times they had to use telehealth, they may had a little difficulty on the software, on the hardware, but I think the more the sessions went by, both the therapist and the family became more familiar, and it was easier to conduct and have full appointments. All right, so before your appointments, it may be beneficial to send a reminder message, an email or text, depending on the caregiver's preference. So I always ask them what is best for them before your appointment. You can remind them to charge their devices and prepare the session material. For some clients, I have to send 2 reminders. Oops, this is the wrong slide. So this one, I'm so sorry, I confused. I thought it was another slide. So here is about having the parent's phone number. Yes, I would recommend having the parent's phone number before the session so you can talk to them. I ask them what they prefer to share, phone number, what is their preference of communication. And ideally, I would like to have a modality, FaceTime, WhatsApp, Facebook, or Skype, that has video support. So this does not have to be HIPAA compliant. This is for you to instruct the caregiver how to use the HIPAA compliant software. So this is just me and the caregiver. The mother may be FaceTiming or using WhatsApp or whatever they prefer. And I would use something they choose, something they are familiar, because you don't want another barrier. You don't want to add another barrier for them. As a plan B, you can have, if you're going to be doing telehealth for quite some time, I would recommend have a second conference software that you use. I do this here. Most of the times, the technical problems can be solved by switching to a different device. So this is, I just give them a few minutes, and if they cannot handle them, this is the first thing that I recommend. Have a written plan for your appointment. So when we start our appointments, we ask the caregivers in case we get disconnected, blah, blah, blah. So we have a way that they can prepare and they know what to do if there is a problem with disconnection. Identify the location you will be and the equipment you will use. We use headsets to protect confidentiality. And make sure that, behind you, it looks professional. On the right side here, you see a picture of Marissa, who is getting ready to have a supervision session. And, it doesn't matter if it's a client or your supervisor, be mindful of what is behind you. Dress code, we suggest to follow your company's dress code. It doesn't matter if you're at home. The lighting, the positioning of the camera to be at your eye level, and have your material ready. Like the data sheets here, you see Naomi, completing, she prints her data sheets. It doesn't really look professional if you stop in the middle of the session to go get something from the printer. So just model the behavior that you expect from your clients. All right. So it may be beneficial to send a reminder message, an email or text, depending on the caregiver's preference before your appointment. Again, I ask the caregivers what it is that you prefer, and you're more likely to respond. And remind them to charge their devices, prepare the session material. For some clients, I have to send 1 or 2 reminders, and maybe one the night before and one a couple of hours before the appointment. And I think that especially now that our schedules have changed, you may need to be a little bit more patient with the families. Set clear expectations about the start and end time of your appointments. I am always on time for my appointments. If I know that I'm going to be late, I always let them know, even if it is 3 minutes late. If my client does not show up at the designated beginning time, I send them a message to check if they are having trouble with the software and how I can possibly help them. Parents of children with disabilities may be less socially active with less friends. Telehealth is a more private modality than in vivo, just like in home services. I have had parents tell me that I am the only adult they talk to every week, other than colleagues at work, and they consider me their friend. At times, I found it challenging to maintain a professional relationship as I saw them struggling, and I was tempted to offer support. My advice is to be clear about your role from the beginning. Also, at the same time, be nice, kind, and empathetic. Parents may have young children at the house, many kids. Maybe they're working longer hours because of the pandemic. Maybe they are in the healthcare industry. Maybe they just lost their job. Maybe they're sick themselves, or they have a relative who is sick, or maybe they're grieving a loved one. We don't know what we don't know. Earlier this week, I had an appointment with a mother, and I entered the appointment and she was not there. The father was there. And I had discomfort in my face, and I said, I have another appointment right after this appointment. And the husband was very apologetic, the father of the kid, and he said that his wife was going to be a little late because the hospital that she was having chemotherapy changed locations. And I didn't know I didn't know they were going through. I'm sorry I get emotional because I have invested a lot of time and I really care about this family, and I had no idea. So my advice is be kind. So last, if you decide to record your sessions, you must use a HIPAA compliant location to store it. If you cannot identify a HIPAA compliant location, just don't record. You may want to review the literature before starting and provide services via telehealth. Leslie did a very good review of the literature and gave us a lot of thought. I recommend creating a telehealth studies folder, and you can include articles that you read and, before or while you're providing services. All right. Connectivity issues during the appointment. Sometimes all they need to do, the family needs to do, is upgrade the modem or decrease the number of devices, especially now that everybody is at home. Maybe all they need to do, if the internet is kind of choppy and slow and the picture freezes, is just ask some of the other kids or the husband to decrease, to get off the internet. Also, change room. Sometimes there is specific rooms in the house that they don't have fast internet access. So maybe just changing the location, this can also help. Hardware or software failures provide access to alternatives. And I mentioned just switching to a device, especially from laptop to phone, can make a huge difference. Poor visibility due to room lighting, just position, be mindful, close the drapes, move away from the window. Last, I just want to say that, and I learned this from Dr. Wacker, during the first appointment, explain to the caregiver that you want to be the fly on the wall. So you want to empower the caregiver. You want to coach them, work with the kid. So you may not be as receptive and engaging with the child when you have your sessions. So I tell them that I just want to observe, I just want to teach you. And again, with the kids that are higher functioning, then I just block my camera view and I just talk to the caregiver through their headphones. I just want to end by asking you to review Lerman et al. 2020. It has two very useful tables. I think the picture here is not good. We have telehealth. We have developed a telehealth checklist. We recommend practitioners to review before providing services, and also a table that covers telehealth related challenges and possible solutions. Today, I only cover technical challenges and very briefly, but you can read the article and you can use the table for advice when other difficulties related to telehealth occur. So my time is up. I'm happy to answer questions at the end. So I'm gonna stop sharing my screen.
Hi, everyone. As we are switching presenters, we're going to do another poll check. This is the third check. If you do not see the poll appear on your screen, I just launched it right now, then please comment down on the bottom of the screen where it says Q&A. Please do not comment in the chat box, but instead comment in the Q&A. Thank you.
Okay, so I'll be providing a very brief overview of telehealth billing. I'll forewarn you, this material is very dry, but I do think that it's also important. So this would be when billing medical claims to insurance companies. Even if you are not directly responsible for submitting your billing, I think it's good to be aware that there are particular ways clinicians should be reporting the location of service. So for example, within our organization, we use Central Reach as a practice management solution. So when our clinicians create their schedule and convert their sessions, they're not putting this coding in, but they're selecting codes and reporting place of service that converts to specific coding that we submit to billing. So there are some decisions clinicians need to make that helps us know which services were provided via telehealth, which is also required by most insurers. So there are a couple of telehealth modifiers. So this would be your category 1 procedural code is paired with a modifier, and that indicates that the service was provided via telehealth. So there are 2 modifiers that are used for synchronous or live telehealth services. The GT modifier is the most common. It can be paired with any CPT code. GT and 95 modifier can be used interchangeably. The 95 modifier also represents synchronous or real-time telemedicine. but it can only be listed with codes in Appendix P of the CPT manual, including behavioral health treatment. I'll share that we always ask our funders upfront how telehealth services should be billed. Some systems will require you to use the GT modifier, and others would require 95. The GQ modifier is used for asynchronous or that store and forward telemedicine, which not all funding sources presently support, but some do. So if the service is not live, I know that there are a lot of insurers now in response to COVID-19 that are approving telephonic care. So if you are providing telephonic care that would be live, for example, you would use a GT or 95. But if a technician were recording a session or a parent was recording a video that you were later reviewing, that would be asynchronous since you're not reviewing that live, and would be used with would be billed with the GQ modifier. There are a couple of codes that are billed by themselves on a single line item to represent a facility fee or a telehealth transmission fee. Not all insurers will reimburse for this, but I always like to mention it because it really is helpful. The most common code that we use within our practice is Q3014. It's billed once per transmission. The place of service that's paired with Q3014 is place of service 11 or the office. The facility or the organization bills for the service, so it's not a code that's billed by the rendering provider. It's always billed under the organization. And there is a medically unlikely edit tied to this code, so you can only bill it once per day unless the insurer has authorized more than once per day. So if there are 2 telehealth sessions in a single day, again, this code can only be used once. The reimbursement for this code is minimal. There are some funding sources like Medicaid in New Mexico publishes this information, so I'll share it's just above $20 per transmission, which doesn't sound like a lot, but it really can help in helping to offset the cost of technology and HIPAA compliant solutions that are required by telehealth providers. The other transmission fee, which we've never used within our practice, is T1014, and that would be billed once per minute. Oops. Okay. So this is just a little table to kind of show if there are providers on site in person with a client, and then there are telehealth providers, kind of what everything would look like on a claim form. So the originating site would be the site where the patient is present. If there is a technician who is in person with the client, the technician would also be at the originating site, and again, the telehealth provider would be at the distance or remote site. In this case, the telehealth provider would bill a place of service 2, and that's for telehealth. Any telehealth service, even if it's approved telephonic care, that would be billed under place of service 2. And then any services where a provider was actually on site would be billed with a separate place of service, just with the corresponding site. Most major private insurers will cover telemedicine, but the coverage can really be policy dependent. So just because you have some patients with Blue Cross Blue Shield of Texas, for example, that are covered under, that have telehealth benefits, doesn't mean that all Blue Cross Blue Shield of Texas members are covered under telehealth. Definitely there are federal plans that utilize Blue Cross Blue Shield of Texas, but they might have different policies related to telehealth. So when we are verifying that a patient's covered, we have a process that we call an eligibility verification review, where we call the number on the back of the insurance card and we provide them with all of the ABA therapy codes to verify that they're covered for all codes. And then we'll actually pair those codes with the place of service 2 to specifically get that authorization or that confirmation that the patient is covered not just for ABA, but also for ABA delivered through a telehealth modality. So that's really important. I would always document when you are obtaining that information, who you spoke to, and a reference number as well, just in case you have issues down the line where someone informs you that the patient actually is not covered for telehealth care. I think the most direct way in just ensuring it's covered is actually providing the codes paired with the telehealth service location. And then just know the guidelines for each payer. So just because the payer covers telemedicine, it doesn't mean that they necessarily cover all codes via telehealth. So some payers have very specific guidelines that they will cover, for example, remote supervision or treatment guidance, but they might not cover 97153 or that direct service via telehealth. So just be really certain that the funder covers it before you proceed. And that is what I have on telehealth and billing. So I will hand it over, I believe, to Dr. Lerman.
Okay, can everyone see that? Sorry about the delay. So thank you so much to the panelists. Lots of great information. I just want to end with a couple slides with some resources. We mentioned at the beginning that the Telehealth ABA Task Force has released its report on providing some telehealth guidelines for Texas. And you can find that on the TexABA website. CalABA also a couple of years ago released one as well. The Council for Autism Service Providers has released some telehealth guidelines, and I believe they are releasing an updated one within shortly. So you might want to go and look that up as well. I found them to be quite useful. In addition, I do want to also direct your attention to Vanderbilt's Kennedy Center. They've got some wonderful videos, training videos for parents that might be very useful to supplement your telehealth. They have been conducting telehealth parent training program for a couple of years, evaluating their outcomes, and they do supplement the video conferencing with some online videos, training videos, and they are available to anyone. They've also been presenting some webinars about telehealth, so I recommend those. So just to wrap up, and we may have time, a couple minutes for questions, research on ABA telehealth services, as Leslie describes, is still in its infancy. There's so much that we don't know, but I think at this point, we can conclude some things about what we can do via telehealth now, given that we are in a time where we need to be, if we're going to provide any support to our families, it's going to have to be done remotely. So based on the current research, we feel comfortable suggesting that you can use telehealth to coach caregivers, others to implement assessments like preference assessments and functional analyses. You can use telehealth to observe and collect data on potential targets. So setting up, a caregiver can set up naturalistic routines so you can kind of observe and see what's going on. You can train caregivers to implement specific programs, as well as provide more general trainings on best practice procedures to expand parent skills. And you can also assess generalization maintenance of skills that you have been targeting in the clinic. I'm going to return to what I call the COVID silver lining in all of this. this is all forcing us to provide support to our families remotely. And this is a great opportunity to help promote generalization of their skills to the home setting, to reduce the family's reliance on a therapist, to force us to think more about what are some important goals for the family, to help expand their knowledge, and to just provide support for the entire family unit. You are essentially going into their homes when prior to this, you weren't able to. And finally, please don't go it alone. I know that there's a sense of urgency because everything just got cut off. And we don't want to just leave our families abandoned during this very difficult time. But you should not assume that you can transfer your competencies to online support. Leslie and Jessica shared some fascinating data with us. They were looking specifically at how well behavior analysts can transfer their parent training skills from in-person to remote modalities. They were looking at, they had 14 core fidelity components when working with parents, such as collecting procedural integrity data accurately and ending the session with a recap of what happened during that session. And they also had 9 supplemental components that were directly related to providing services via telehealth, such as starting out every session with a check of the technology. Her participants for these pilot data were 3 behavior analysts with 2 years of experience. And what you can see on this graph are the percentage of steps completed correctly across those 3 behavior analysts. On the left panel, they were getting feedback from a trainer when they were providing face-to-face parent training. And as you can see, a nice increase to 100%. Then there was that switch to remote parent training. And what's fascinating about that, where you see the red circles, behavior, their skills plummeted to 0. And that included the original 14 core components. And so I want to just end. To me, these data say a lot. I know it's just 3 individuals, but you should not assume that your skills were transferred. Please reach out to people who have some experience in this area. Take all the opportunities that are being offered. There's a ton of webinars going on to help you with telehealth. And with that, I don't know, we have 3 minutes, so I don't know. We want to take some questions. So I'm not exactly sure. I see that 2 participants raised their hand.
We have a number of questions that are in the Q&A box that are specific to some of the panelists. And then we have a couple people who've raised their hands. So which would you prefer to take first? The answers that are written or the raised hands?
I don't know. I'm new to this. I've been trying to answer some of the questions throughout the webinar, as other people have as well. So I'm not sure what would be easier.
Well, the panelists have a moment to look at some of the questions. I'm going to launch a 4th poll. If you don't see the poll, please comment in the question and answer marked Q&A below. Thank you.
I suppose we could take the question for the person that's been waiting the longest, Zach. That might be a thoughtful thing to do, unless it's going to be something that's going to be terribly embarrassing.
Well, there's actually a couple of questions I would like to answer just really quickly.
Do it.
Someone asked if anyone's conducted telehealth direct therapy and not RBT supervision or parent training. Right now, there are no published studies on providing direct ABA services. There is one that will be coming out in the Journal of Applied Behavior Analysis. This is going to give me also an opportunity to share something that very few people know, and that JABA is putting together a special section on both telehealth and public health that we hope will come out in the fall. And in that special section, there may be a study that I know has been accepted and will be published in JABA and it's the first one of someone providing direct therapy, and it's to adults.
Thank you.
Okay, I suppose I will start with the oldest question, and this was from 3:44 p.m. Stephanie asked, "Is there anyone who has officially communicated with HHSC regarding delivery of telehealth behavioral services through the class waiver program?"
This is Gordon. I'm not aware of anyone that has specifically done that. I know within the Texava Public Policy Group, we have that issue has been raised. I think, anticipate raising that question. There's just so many things right now to which we're trying to get answers. My understanding of the situation at present is that HHSC has given its blessing to doing telehealth for some of the Medicaid waiver programs, such as HCS, pardon me, the deafblind program, Texas Home Living, but I'm not aware from class yet. I specifically asked someone who was in contact with class, with the folks in Austin, and they said not at this point. So I'm not sure what the situation is, but that is one of those issues that we need to perhaps follow through on.
All right. Someone asked if we could touch base again on 97153 in telehealth.
Yeah, I think we would just need more clarification as to whether they're looking for guidance on safe and effective implementation or whether insurers are approving it. I know some are and some aren't at this point.
There are many unanswered questions for which many people are searching for clarity, and that's one of them.
I do want to answer this question. Is it ethical from a billing standpoint to conduct direct ABA therapy to clients? Would any of the panelists like to address that?
I'm willing to take a shot at that. So I would say it really depends on the individual variables. Given that, so you can refer to like the ethical code items 1.01, reliance on scientific knowledge. So for that, there's limited evidence base, which is what we've been talking about for what we typically would call direct treatment. So there's nobody facilitating on the other side with your client. It's just the practitioner on one side of the screen and the client on the other. That's kind of what we're talking about with direct treatment, I think is what many people are referring to, and that practitioner is the person responsible on the other side of the screen. In that case, there's very little out there supporting it, or none, right? No scientific articles at this time. But you are weighing different, whenever you're making an ethical decision, you're weighing different factors. So you're also weighing involving the client in planning and consent. So if you're doing something that isn't established by the scientific knowledge necessarily, or it goes beyond the scope of that, then you need to make sure that's clear in your consent process. You're also looking at the individualized behavior change programs, 4.03, and thinking about what are the context variables for the person I'm working with, the client that I'm working with, and what's most appropriate in this circumstance. The temptation is always to give we want to give a blanket answer for what's ethical versus what's not. But unfortunately, that's not the way ethics work. It's case by case, and you're weighing pros and cons of a lot of different factors.
I'd like to chime in and endorse what Jessica said. The short webinar we did on Tuesday, that issue came up, and I'm sure will continue to come up, but that's we have to look at the scientific evidence base. That's critical. And as Jessica said, and as I mentioned back on Tuesday, that we have to also weigh those decisions. I think it's just like Jessica said, case by case, person by person, and an issue perhaps could be made that if there is a extreme risk of harm to someone, as I think Leslie said, a physician there at their she knows had said, if there's risk of going to the emergency room and you can help reduce that risk by intervening or interacting directly via telehealth with the client, then perhaps you should. It's perhaps the good Samaritan rule would cover. But again, this is my personal opinion. It's not the opinion of Texava PPG. But those are tough case by case decisions that have to be made.
I'd like to say maybe just one aspect of that is direct service to a client, though, is still experimental. So it would not be offering an evidence-based service. There is not, research to support it. And so just, I can't tell anybody what to do, but if you are considering the cost benefit, typically if we're offering something to experiment, we don't charge for it. So just something to note.
This is a good time for people to perhaps arrange to do some research, but again, all the research precautions are incumbent on us, like explicitly acknowledging that what we're entertaining is based on sound principles, perhaps, but not evidence-based at this time. Get whatever necessary explicit consents and reviews pertaining to experimental research that would be indicated.
So someone had a follow-up question. They said that they work at a center. It's still open despite their protests and they don't feel comfortable going in any longer. They've switched to working from home. Can you guys touch on how to still bill for their services even though they're making a personal decision to work from home?
Does the nature of the decision factor into billing? I'm not sure how it does. I think it's locations like Kathleen was talking about, place of service and all that.
Right. I think that it would just depend on whether or not the funder, so whatever insurance company your patients are covered under, approves telehealth, and whether or not your organization is going to approve you to provide telehealth while you're at home.
I think you would still need to, if we're going to do that, we still need to make sure that we have all the relevant consents for doing telehealth. That doesn't change. And we need to make sure that everyone is aware of it and that the billing people adequately reflect the difference in vivo versus telephonically or telehealth wise.
We had two more questions about code 97153. One person asked, if you have minors during 97153, it wouldn't be accurate to conduct direct therapy because the parent would be delivering the services, correct?
If they are, you can be coaching and supervising. Then you'd have to use the appropriate code for that. I think, Kathleen, you know more than I do about the billing process.
Yeah, I'm hesitant to answer this one. I think we are still waiting for guidance on what this is going to look like, to be honest.
Again, we have to make sure that we do not inadvertently or advertently misrepresent what we're doing in the place of service. As Kathleen said, can be some serious sanctions.
And then the other question about that same code is, if the would it still be 97153 if the RBT was online and the parent was with the client?
My understanding from people here in Texas is that there has been some permission for that, at least in some cases. But again, transparency is critical. Make sure what's right for what that policy will do.
I think that point, transparency, is so important. So if you're reaching out to people that are more senior in the field, that have more experience, and saying, hey, this is the circumstance, what do you think? And then you're also reaching out to the payer and saying, this is what I'm considering doing. Is this, is this valid? Will this work for your company, for insurance? And if they approve it, if it's all transparent and out there, that really decreases the likelihood that you're going to go wrong. And that transparency also carries forward through the consent process with the parent.
And document who you talk to, or get things in writing, so email, something. I think Lucia made that point.
So the next question, is there any documentation or a reference that shows we are able to use telehealth for HCS or TXHML? I heard you say it was allowed, but where can we find that information?
My understanding is that has been provided. Actually, I've received an email, I believe it was a policy statement or something from HHSC in Texas saying that was the case, but Kate or some of the other folks that are panelists perhaps address that more explicitly, but that's my recollection of having seen that document. It should be available on their website.
Yeah, this is Kate. I do have that. I'll forward that to Zach, and maybe he can put that reference on the TexAva website of how to click to that link for Texas Home Living and HCS.
Yes, I can put that online. For those of you who are still in the room, TexAva has been collecting some valuable resources and putting it on our coronavirus resources webpage. We're also putting some stuff on the resources webpage on TexAva. So keep an eye on those web pages. We'll be updating those consistently. The next question, has any research been done on doing social skills groups via telehealth?
I'm currently working with some colleagues in doing a peers program. And I know the peers group, they're out of UCLA, they're working on translating their program into a telehealth model. That's what I wanted to share.
And just from review of what we found is that there was certainly individual social skills that were targeted. Typically though, it was joint attention or reciprocal play, stuff like that, but it was individual, which seems pretty interesting now that I think about it, but it was all very early childhood, less kind of that, what Jess is talking about, peers and older individuals. Telehealth is a social skill that needs to be learned anyway. So, I mean, Zoom at least, right? We're all learning it.
Yes.
So next question, do you agree that if we are to consider research at this time, there may be the risk of undue pressure on parents due to the need or desire not to lose services? I think this can also be very tricky in regard to consent.
Yes.
And that's a good question because we could not offer them an alternative. Typically, when we're offering telehealth projects, it's completely, consensual and they have other options. They have options out in the community. But yeah, you're correct. That is certainly something to consider, that in this context, this is undue, I guess. I don't know how to mitigate it though.
There's certainly case precedents for not telehealth specifically, but with regard to the general issue of consent, where the options are highly constrained, it's perhaps very susceptible to be considered coerced consent and not truly valid informed consent. That many governmental agencies have run into that over the last few decades. So please be careful. There's not a simple, easy answer.
Right. I would say it depends. It's all about the options available to the client and that they're aware of those options and whether or not there are any repercussions to the choices that they make. So you might think of putting undue pressure on someone if you're saying you have to continue receiving these services or risk losing your spot in our center, or we can't promise we'll be able to ever serve you again in the future if you don't continue with us now. That to me sounds more potentially problematic than saying
Yes.
that we are offering telehealth to you if you'd like it, because there's no other option that's available at this time. And that would be, there's still multiple options that people are being given right now is the reality. But in some cases, like in my case example I discussed earlier, the family may, or the organization may decide that they're doing no more face-to-face, but that's just one circumstance.
All right, the last question I have that's open right now in the Q&A. Do you know if peers will reach out to trainers to provide some additional training on that?
I would guess not. I think you mean like capital PEERS. I think you're talking about the peer social skills program.
Yeah, capital PERS.
For that, we reached out to them and said, what resources do you have for translating to telehealth? And they responded very quickly.
Is there anybody else that would like to ask a question? You can raise your hand or submit a question in the Q&A box. All right, I'm not seeing anything. Oh, wait, we have one. Janet Schaefer just raised her hand. Go ahead, Janet. I think you can talk. There we go. Janet, go ahead.
Hi, this is Jan Schaefer. I know many of us have been waiting to see if TRICARE was going to be approved, and I am getting rapid messages saying something from John Hopkins saying it has been approved for 91756 through May, unlimited through May 30th. Has anyone else heard that?
Perhaps that information will be broadcast more extensively shortly. I hope so. That's very important. I know Berenice has raised concerns about TRICARE there in San Antonio. I'm sure Jessica sees it all the time. But we all need information. We have to have.
Yeah, I saw that posted on Facebook. Somebody posted that from it. But in fact, just today I heard from them that no, they're not authorizing them. Like, I mean, just a direct to myself from a request that I made. But, you know, I don't know. So I would think that it's not on their webpage. I looked for it already, but hopefully we'll be hearing something.
Yes, this morning the PPG received word that it was a hard no from TRICARE, but one of the officers on the PPG indicated that there's a lot of work going on, and hopefully that will change. But like many things these days, it seems like things change minute to minute. So I just keep your eyes and ears open.
Okay, we have one person with the question. Has anyone started any virtual sessions? That was from Sterica. I don't know if we need more clarification on that question.
Yeah, what do they mean virtual session?
I think the question is just, is anybody currently providing telehealth?
I think most of the panel members are.
To go back to the Texas Home Living and HCS, I did post the link in there. You can see where the link to hhsc.gov, and then a few lines down, I posted the exact wording. They call it face-to-face or video conference, or by speaking by telephone with an individual. So you can do all of those things per the billing guidelines for Texas Home Living, and HCS are similar.
So they're using the term video conferencing. That basically is video telehealth as far as we understand.
And I just want to add that the PPG just learned yesterday that anyone providing VR services, those services are now approved for telehealth as well.
As well as if you're doing any ABA treatment through, or any treatment through ECI.
Any other further questions?
Looks like Alicia's raised her hand.
Yes. Go ahead, Alicia.
Am I unmuted?
Yes.
Oh, perfect. Hello, everybody. Hi. So if you had to pick a platform to go with right now, okay, because you just had to go with it, which one would you pick?
Zoom.
Okay.
I second Zoom.
The reason is that it is so easy. You just email a link. The person doesn't have to have an account. Anyone can figure. I've never had anyone not figure out how to use it. Even my very technologically challenged 80-year-old parents.
And a lot of people are saying the screen share function is something that you don't always get in a lot of the other platforms. Now, the question is that considering the HIPAA regulations, I guess, have been waived at this time, does that mean that, like, do we just go with the free Zoom for now? Or should we look into, like, for instance, purchasing it, considering it there's a sale? Because it goes into the financial aspect too. Are we going to continue this model afterwards too?
Right. I mean, I think Gordon really touched on this nicely when he said, the federal agency has said that they are relaxing, but to the extent that you can, you really should. And so I would look into the paid options to get your BAA.
Yes.
And that's specifically the telehealth platform, because it's now they've switched up their marketing attack. I've noticed a lot of people are definitely marketing all their different platforms, and it's specifically the telehealth one, not just the paid personal one. Right? There is a difference.
You have to get a BAA. You have to get a business associate agreement. And last year when I contacted Zoom, the minimum for me was 20 licenses at $1,800 for the year.
So right now, just so that I don't know if anybody else is on here, but they are running a special where if you purchase the whole year, you get 40% off. So it comes down to be $166 a month. And you get up to 10 hosts, I believe.
Well, they also have a drone delivered paper products to your door.
Yeah, I know, right? Because that could be helpful too at this point. So, right? Oh, goodness. All right. So you guys would see.
For healthcare.
Yeah, right? Oh, if they could only, this is like the wild, wild west right now. So, I appreciate you guys taking the time. Great. So that gives me some reassurance because we are going to go live with Zoom next week. So yeah, we're working on getting all the parents to sign the consent forms, set up their schedules, and then we're sending out parent packets and newsletters in the meantime, as well as additional assistance with like activities and minute by minute, as somebody said, minute by minute. So, all right. Thank you. I appreciate it.
All right. We also have a raised hand from Caroline. Go ahead, Caroline.
Can you hear me?
Yes.
Okay, so really quickly, so I know when working through the parents through telehealth, we'll usually use the BST model, and I know even the modeling component of that is still, you'll ask the parent, like, do you want me to model or can you do it yourself? But whenever they have needed that modeling component, do you guys usually like send resources afterwards to make sure that they know exactly what you're talking about, or how do you navigate the modeling part part where you're not actually there.
Take it away, Lucia.
I have a teddy bear. I have a teddy bear. I got in a conference and I used the teddy bear to model, for example, for the toilet training study that we were showing the caregivers how to exchange a picture to mount for the toilets. I had the picture and I would say to the caregiver, place your hand gently on top of your son's or daughter's hand. And I would have, let me get a binder from Kelsey's desk. And I would have the, your child pick up the card and then place it on your hand. So I would just use modeling with my teddy bear.
Right, but this is live in the session while the kiddo is there, or is this after the fact?
No, it was before.
Okay, that's what I was
didn't have the child. No, this was when I was talking to the caregiver. When I had nobody around with me at the office, no student or colleagues, I would use the teddy bear.
That's parent training.
Okay, so maybe jot down like certain skills that they need to learn or certain things that they need to get better at, and then addressing them before the next session or right after the one that you just had.
Either way.
Okay.
Yeah, I would add you could also do like a video modeling because sometimes live modeling, not all of us have Mr. Teddy Bear with us, right? Although that's a great idea, or a Confederate, right, that you can use for modeling. So I've used video modeling before where if I saw something, I'd send it to them and then try to, do that simulation modeling right before the next session or is typically recommended.
Awesome. Okay. Thank you very much.
I also do augment the telehealth services that I provide, or like most services I provide, with written and visual supporting material. So some kind of like written recommendations or visuals to support what you're saying and showing.
All right, we have one more live question from Tyrell. Oh, nope. Hold on. There we go. Tyrell, go ahead.
Okay, thanks. I obviously need to get better at the technology part. Somebody mentioned, I think, like a technology TA for their parents. Would y'all be willing to share that with us? For our parents by any way chance when we start
it depends on the software that you use. So what is the software that you're going to use?
Well, I think it sounds like y'all are all recommending Zoom, so that's what I was going to go with.
Yeah.
Zoom actually has really, I looked into this and we have like a very basic one because Zoom actually has amazing resources on their website. They have checklists, they have videos, and I didn't realize that until I started trying to put it together. And then I gave it to one of my TAs, which I was like, what are you talking about? My teaching assistants. And they went and looked and they said, Zoom has everything. So I think their technological support is really strong.
Okay, thank you.
– Zach, maybe we're about at the time for the benediction.
We can go ahead and end here.
Time for happy hour.
Virtual happy hour, right?
Yes.
Thanks everyone. Thanks to the
Thank you all so much for doing this.
Live long and prosper.
Thank you. Bye.
Bye. Have a good weekend. Stay safe.
Have a good weekend.
Bye, everybody.
Thank you all.
Bye, everybody.
Bye-bye.
Bye.